A very good evening and a warm welcome to all our viewers. I'm Dr. Shitil from the Clinical Engagement team at DocPlexus. Welcome to the brand new session of the Venous Association of India MasterSeries. Thank you for showing so much love for our past webinars by Dr. Rahul Jindal, Dr. Patel, Dr. Roy, Dr. Selvaraj, and many others. Also, a special thanks to Dr. Bedi for his consistent effort in setting up this informative series for our DocPlexus community. VAI has been instrumental in promoting the knowledge about venous diseases, their pathophysiology, investigations, latest therapies, and research in venous disorders. Venous diseases are a vast problem and include chronic venous insufficiency, varicose veins, DVT, pulmonary embolism, and many more syndromes and disorders. So these sessions will be knowledgeable, sharing knowledge sessions from expert lectures in collaboration with Venous Association of India. For today's session, we have with us Dr. Sriram Naryanan. He is the current director of the Venous Clinic, senior consultant vascular surgeon at the Harley Street Heart and Vascular Center, Singapore. Dr. Sriram specializes in vascular surgery and has clinical expertise in vascular repairs for chest and abdominal aneurysms. He has a keen interest in computer modeling of Asian aortic aneurysms. Dr. Narayan is also an adjunct assistant professor in the Young Lu Lin School of Medicine at the National University of Singapore. He shall be talking about pelvic venous disorders, part 1. Welcome to DocPlexus, sir. It's a pleasure to host you here today.
Thank you. Thank you. I will share my screen now, if that's okay.
Sure, sir.
Give me a second. Okay. Thank you, Shitil. Thank you, Dr. Bedi, for your invitation. Thank you to DocPlexus for organizing this, the Venous Association of India for what they do for vein disease all over the country and around the world. And it's a real pleasure to be with you all in this master series. I have specifically divided this series into 2 parts on pelvic venous disorders. The first part is aimed at those people who would see these patients but may not actually have to manage them. It is important for them to make a diagnosis and make the appropriate referrals. The second part, which is due in 2 weeks, is a slightly more advanced talk. It is on the technical aspects of how to actually interpret the ultrasounds, how to perform the procedures, and how to choose which procedure is the right procedure for each patient. I shall then move on to what is an extremely common condition, which is pelvic venous disorders. For a long time, it used to be called pelvic congestion syndrome. And really, pelvic congestion syndrome is a bit of a basket diagnosis. It means the patients have chronic pelvic pain, and we don't quite know what the cause is. It has a huge symptom overlap with a much commoner condition called endometriosis, although the 2 of them run side by side. And these symptoms are so common among women that sadly, they're often not taken seriously. In fact, if there's one thing that causes distress to these women beyond the fact that they have to suffer their pelvic pain, is the fact that their symptoms are often dismissed by friends and family and specialists who don't quite understand it. And the list of symptoms on the left really gives you an idea of how common it is. Chronic pelvic pain is fairly common. Period pain occurring in women is considered normal. They have low back pain. They have painful periods. They have pain during sexual intercourse, heavy bleeding during periods. They are unable to hold urine. They can have a bit of incontinence. There are strange bowel symptoms. There can be constipation. There can be a bit of loose bowel. And then many of them suffer from some fatigue and what's called brain fog, a bit of confusion and unable to focus. They can have fainting from the pain sometimes or just dizziness. Now, these are such common non-specific symptoms which are associated with chronic pelvic pain and the menstrual symptoms, that the patients are constantly passed between one specialist to another. So the lumbar discomfort could go to an orthopedic doctor. The dysmenorrhea and the painful intercourse could well end up with a gynecologist. Urinary symptoms with a urologist. Brain fog and fainting and dizziness with neurologists. You can have gastroenterologists involved. And it is sad that it has taken us so much time to actually understand the basis of pelvic congestion syndrome, although from May this year, the name has now been changed to pelvic venous disorders. And through this talk, you will understand why. So let's get started on this. And what is the aim of today's talk, which is for you to understand the pathology that underlies what is a pelvic venous disorder. And then how can you predict from its clinical presentation what might be the underlying pathology? There are non-pelvic symptoms, like I said, associated with it, related to the abdomen, to the bowel, and to fainting and dizziness, how to understand that association. And how, most importantly, must you distinguish it from the common endometriosis. Remember, 1 in 10 women probably have endometriosis. 40% of all women have chronic pelvic pain. Pelvic venous disorders, about 15 to 20% of women have pelvic venous disorders. You must understand the need for dynamic imaging. We seem to think that ultrasound is a sort of lower hierarchy of imaging, and that if you go to a CT or MRI, it's a superior form of imaging. That is not true. CT and MRI are static, single anatomical pictures. They don't show you the functional disorder underneath in the hemodynamics of the blood flow. You need a Doppler plus an ultrasound or a duplex scan to actually pick that up. And I will introduce you today to a simple diagnostic algorithm for pelvic venous disorders. I will emphasize on the use of this algorithm in the next talk in 2 weeks. But it's important to understand this condition because, as it's written below, what the mind doesn't know, the eyes will not see, and the brain will certainly not record. So the problem these women have had for all this time is that, firstly, there has been a lack of knowledge. And it's nobody's fault that there's a lack of knowledge. We just didn't have that knowledge. In about 2003 to 2007, we began to understand the anatomy of veins in the pelvis and the compressions that take place there normally. The public themselves think that period pain is normal, heavy bleeding is normal. There is a fair amount of staying quiet about it and women being conscious about talking about these symptoms, certainly about sexual intercourse being painful. That's not an easy topic for them to speak about. And sadly, the interventions for pelvic venous disorders like coiling are fairly technically easy to do. And that is both an advantage and a disadvantage. The disadvantage is it is easy to do. You can do it quickly. You will do the wrong procedure in the wrong patient without doing the full gamut of testing or assessment that you need to do. So it becomes a source of easy income, and that is something we would really try to avoid. Because in truth, less than 3 women in 10 actually will need a surgical procedure for this. So if they're actually having a lot of surgical interventions, then you're probably overtreating the patients. So what is the basic pathology? The basic pathology is this: we were never designed to stand. We were supposed to live our life on all fours. Unfortunately, Darwin came about and the theory of evolutions came about. And the issues we've created are that we are standing for long hours, a posture we were not designed for. We were certainly not designed to sit for long hours in front of a computer. We were not designed, as the fashion statements have gone around the world, to be extra, extra slim. And so BMI less than 21 can actually be a disadvantage. We were not designed to have pregnancies in 34, 35, 38 years of age. We were designed to get pregnant and have children fairly early in our reproductive life. And certainly with all these Zoom meetings and COVID causing shutdowns and lack of travel, people are staying up till 1 o'clock, 2 o'clock, talking to offices in the US and in the UK or wherever. And we were not designed to sleep at ridiculous times like 2 a.m. There is a cortisol rhythm in our body, and that is important to maintain your health and your vein health. And that has gone haywire in this COVID period, with people sleeping very late, their cortisol levels stay high for too long in the night, and they end up with floppy veins and all sorts of stress-related conditions. It was known as this thing called May-Thurner syndrome. May-Thurner syndrome, you probably all have heard of, is compression of the iliac vein by the overlying iliac artery. It was thought to be rare, and then we realized from cadaveric dissections it's probably a little commoner than that. But once we developed intravascular ultrasound, we realized that almost 70 to 90% of us have it. It is so common that it is almost normal to have some degree of compression of the iliac veins. And therefore, to treat somebody purely on the basis of some compression seen on a CT or MRI is absolutely incorrect. This is almost normal for being a human being to have some degree of compression of the iliac vein. That does not mean they require treatment. But we also now know that the compression is not just at one site in the pelvis. The way the arteries cross the veins in front of the spine mean there can be at least 5 to 7 different points of compression. But the left iliac vein compression remains the commonest site in about 60 to 80% of people. And then there is a strange story. Varicose veins, 60 to 80% occur on the left side. Deep vein thrombosis is about the same on the left side. Venous ulcers are about the same on the left side. Ovarian vein incompetence is about the same on the left side. It's a remarkably consistent story. And so is what we now call the non-thrombotic iliac vein lesion. We no longer try and use the term May-Thurner syndrome, because the truth is May and Thurner didn't actually discover the condition. They borrowed the discovery from somebody else and published the paper first. The other problem with standing up is the association of the left renal vein with the superior mesenteric artery and the aorta. The superior mesenteric artery compresses this left renal vein against the aorta as it passes from the left side towards the right side towards the IVC. And this is really called the Nutcracker phenomenon or the Nutcracker syndrome. And you can see here from the left to the right, the left renal vein crosses and it gets caught between the superior mesenteric artery and the aorta. If you have a bit of weight on you, there is a fat pad that lifts the superior mesenteric artery away from the aorta and so reduces the compression. But women who are extremely thin, this fat pad is absent, so they're more likely to have a greater compression. And really, pelvic congestion syndrome or pelvic venous disorders are probably a little commoner in women who are extremely thin. So this Nutcracker syndrome is compression of this left renal vein, and there's a high pressure system that develops in the left renal vein due to this compression. Some people may have a retroaortic renal vein anatomically, which is fortunately rarer, and they will also have an additional compression on the left renal vein. You must remember that the compression of the left renal vein in the aortomesenteric angle doesn't only take the pressure towards the kidney, because the left ovarian vein drains into the left renal vein. So there is transmission of pressure backwards into the left ovarian vein. And the ovarian vein then communicates with veins around the uterus, the uterine body, the pelvis, the perineum. You have what are called the adnexal veins, the paraurethral veins, you have the paravaginal veins, and they all get caught in this high pressure system. And essentially, you then begin to develop varicose veins in the pelvis and around the vagina and around the uterus. And that is the genesis of a pelvic venous disorder. So PCS or pelvic venous disease is caused by this raised upstream pressure, this high pressure in either the left ovarian vein or the left internal iliac vein. We are often seeing people do coil embolizations on the right side of the right ovarian vein routinely. I find that surprising because the right ovarian vein drains directly into the inferior vena cava, is not caught in the Nutcracker mechanism, and is only rarely, very rarely required to be treated. It should not be considered a standard that the right ovarian vein and the left ovarian vein should be treated together. The left should be treated first, and if required sometime, maybe 1 in 50 patients will require a right side treatment as well. So pelvic congestion syndrome is basically pelvic venous hypertension. In about 10% of people, due to multiple pregnancies, you can have persistent dilatation of these ovarian and uterine veins. And that's because the blood flow increases, obviously, to the uterus to supply both the expanding uterus and the growing baby. And the veins can be left fairly large with an increase in blood flow anywhere between 15 and 20 times normal. Estrogen itself and also progesterone will cause these veins to stay dilated and stay floppy. So women who are hyperestrogenic or have had multiple pregnancies are likely to have dilated veins, and that is primary PCS. But in 90% of people, there is an anatomical compression, either at the level of the iliac vein or in the form of a retroaortic left renal vein or a Nutcracker mechanism that takes place. And about 10 to 15% of women will be affected by this during their lifetime, creating the symptom complex of pelvic pain, congestive dysmenorrhea, which is period pains that really start getting bad just the day before the period and are really bad on the first day of the period and then subsides. They can have dysfunctional bleeding because varicosity is in the uterus itself, and they can have painful sexual experiences. And here it is important that intercourse is not just painful during intercourse, but there is something called post-coital pain, pain that persists after sexual intercourse, and that is typical of a pelvic venous disorder. So that history also becomes important as we go further down this talk. So to summarize that primary pathology, it's a pelvic venous disorder, and then you have all these veins that gather around in the pelvis, causing varicose veins in the pelvis. Some of these will leak through the pelvic floor into the superficial perineal pouch. So that's around the vagina and around the vulva and the perineal region, and even hemorrhoids. And so it is essentially a dysfunction caused by venous hypertension, veins leaking through the pelvic floor, and a large pooling volume of venous blood, which is low in oxygen and relatively low in pH, that then sits around in the pelvic floor. Now, these pelvic veins also communicate with veins in the leg. So in addition to having pelvic symptoms, limb symptoms come into play. So you can have varicose veins, leg swelling, things that get worse just before or during the period. And this is typical of a pelvic venous disorder. We must understand the pelvic venous network if one is planning to treat this. I will briefly go over it. The ovarian, uterine, adnexal, vaginal, and leg veins are all interconnected in one venous network. And essentially, those two red lines tell you where these venous connections are there, around from the obturator, the gluteal, the round ligament, and the perineal veins. And those are the escape points from the pelvis in through the pelvic floor into the lower limb. We now recognize at least 4 escape points: the P point, I point, O point, and G point, which is the perineal point, the inguinal point, obturator point, and the gluteal point. So if you see patients with varicose veins in the back of the thigh coming under the gluteal fold, if you see patients with groin varicosities or vulvar or perineal varicosities, you are looking at a pelvic venous disorder. And this angiogram, which was taken off the net, really shows you how these veins leak through the pelvis into the paravaginal veins, into the superficial perineal pouch, and you can see this arcade within the uterus itself filling up with contrast. Remember, the dye has been put through the catheter only into the ovarian vein, and it is all refluxing backwards into all these veins around the pelvis and the vagina. So some of you might have seen varicosities around the groin like this and around the vulvar region. And this is essentially the pelvic floor losing its ability to stop the transmission of pressure from above the pelvic floor in through the superficial perineal pouch and towards the limb and the back of the thigh. Now, the most common question that is asked is, how to distinguish between endometriosis and a pelvic venous disorder? Endometriosis is a very, very commonly made diagnosis, even without there being any definite proof that they have endometriosis. And these patients are then offered either hormone therapy, oral contraceptive pills can be a problem, progesterone-only pills. If it is endometriosis, it is very beneficial. If it is not endometriosis and a pelvic venous disorders, those veins are going to get worse and the symptoms are going to get worse. They often have Mirena coils or coils, intrauterine contraceptive coils inserted in order to try and control their periods. If it is again endometriosis, it would be helpful. If it is not endometriosis, then it could make things worse. And the key question when a patient presents with chronic pelvic pain and some menstrual symptoms that you want to ask is, do I send it to a pelvic venous disorder or a vascular surgeon who deals with it, that sort of specialist, or should they go to a gynecologist? The first question you need to ask, have they had infertility or do they have multiparity? Women who have had multiple children are obviously more likely to have pelvic venous disorders for the reasons I said. It causes the veins to dilate. On the other hand, endometriosis really leads to infertility in most patients. And therefore, this is an easy early distinguishing part of the history to tell you which route to take. The next question to ask is this chronic pelvic pain, is it cyclical or non-cyclical? Because pelvic pain is present in both these conditions. And in later endometriosis, pelvic pain is no longer cyclical, it stays throughout the period cycle. But in the early stages of endometriosis, the pelvic pain actually follows the cycle, because obviously the endometriotic tissue is hormone responsive, just like the lining of the uterus or the womb, and therefore it will follow the same pain pattern, but later on that pattern is lost. So it is important to ask, did this start as a non-cyclical pain throughout, in which case it is more likely to be a pelvic venous disorder, or was it cyclical from the beginning and has then become non-cyclical, in which case it is more likely to be endometriosis? The third symptom to think about is lumbar discomfort. Now, this is typical of a pelvic venous disorder because when the posterior pelvic floor gives way, they get presacral varices, and essentially they sit on their varices, and therefore they get pain and lower lumbar discomfort. Dysmenorrhea or painful period typically is congestive, which is to say day before the period, first day of the period, second day of the period. That's how it starts, and it is far more consistent with endometriosis. Pelvic venous disorders, the dysmenorrhea is not usually congestive, although there is painful periods. Dyspareunia or painful sexual intercourse, again, like I said, if it is coital, especially during intercourse and deep penetration, it is far more likely to be endometriosis. Post-coital pain, pain that persists after intercourse and in some patients can last for up to a day or even 2 days, that is typical of a pelvic venous disorder. And that's because there's congestion of the pelvis during sexual intercourse, and then that congestion persists and leaves symptoms afterwards. Menorrhagia. Menorrhagia does not occur in endometriosis usually, unless they have adenomyosis, which is endometrial tissue within the uterine body. Usually menorrhagia occurs in pelvic venous disorders. That's heavy bleeding with clots, bleeding that can last for many days, 6, 7, 8, 10 days. I'm currently treating a lady who's had periods that have been on for the last 2 months. And this occurs because there are varicose veins in the uterus, in the body of the uterus itself. And this is far more likely to be a pelvic venous disorder. In the past, many patients who have a pelvic venous disorder have been diagnosed as having adenomyosis because we think they have adenomyosis with pelvic pain, but we now know that that distinction can be made on ultrasound. Urinary frequency, well, urinary frequency again tends to occur especially in women who've had multiple pregnancies because of a weak pelvic floor and changes in the bladder neck angle, urethral angles, and hematuria. Now that can occur both in a pelvic venous disorder because there are varices around the ureters, or there are renal varices because of back pressure in the renal vein, but it can also occur in endometriosis. So it's not a very distinguishing symptom, hematuria. But hematuria that is cyclical, that is endometriosis. Then you can get odd bowel symptoms. In pelvic venous disorders, it is usually associated with POTS, a condition called paroxysmal orthostatic tachycardia syndrome. I will come to that. Or of course, bowel symptoms can occur in women with endometriosis because there are endometriotic deposits on the bowel itself. And then you have a strange symptom complex, which I will come to, with POTS, which is some fatigue, some brain fog or confusion, and some fainting and dizziness, especially on change in posture. This is not typical of endometriosis unless the pain is so severe that it leads to fainting or dizziness from the pain. It is far more typical of a pelvic venous disorder. So chronic pain and menstrual symptoms seem like a sort of blanket set of symptoms many women may have. But if you tease out the type of symptom it is and when it occurs, you will get a fairly good idea. Are they down the endometriosis route, in which case it's a gynecological diagnosis, or are they down the pelvic venous disorders route, in which case it's more a vascular diagnosis? Now, what does happen in POTS? Well, essentially, as I showed you, that this huge pelvic venous reservoir, the blood tends to pool in the pelvis. Patients can have between 500-600 to almost a liter plus of blood, that venous blood, that pools in the pelvis and does not drain in these varicosities in the pelvis. And they suddenly move, they shift position, they suddenly sit up, or they move in the bed. And there's a large shift of blood volume from this pelvic venous reservoir. And if they have some degree of hypersensitivity in their vascular autonomic system, they react with tachycardia, they can get low blood pressure, they can get all sorts of cardiovascular sort of vasovagal symptoms, which essentially is the basis for POTS syndrome. And if you look at this reconstructed CT, this is a patient who has an NIVL. You can see that the iliac vein is compressed by the iliac artery. But look at the sheer size and volume of those pelvic varicosities because of back pressure in the internal iliac vein. So this is the sort of patient who would have a large pelvic reservoir. They need to move this around, and they will get the symptoms of palpitations, of dizziness, fainting on postural change. There can be unexplained abdominal symptoms because of the hypoxic blood in the pelvis and around the bowel. They have heat and cold intolerance, which is a part of their dysautonomia or their autonomic dysregulation. They have brain fog because they're suddenly hypoxic, they're suddenly almost hypovolemic. And of course, they can get fatigue from a combination of low hemoglobin, from heavy bleeding, and they will typically tell you they have episodes where they just can't move suddenly. And one must understand 40% of patients who have a pelvic venous disorder will have some degree of POTS syndrome symptoms. So one has to understand POTS as well, because that can be the primary presentation. So it is a condition where typically on change in position, there is a heart rate increase by up to 30 beats per minute. 40 beats is for people who are 16 or younger, within 10 minutes of change in position, and without any orthostatic hypotension. If there's a sudden drop in blood pressure, then it is not quite POTS syndrome. In POTS, you only get tachycardia. Postural hypotension has other causes that require cardiological investigation. Now, this intolerance is a fairly broad term, and all these symptoms that we talked about can occur because of this change in posture. And dysautonomia, of course, is a fairly non-specific term for any abnormality of the autonomic nervous system. So when you get these symptoms with pelvic or menstrual symptoms, pelvic pain or menstrual symptoms, think POTS. Typically young women, 20 to 40 years old. Symptoms tend to be bothersome in the morning because they've been in bed and there's a lot of pelvic pooling of venous blood. If there's a viral illness or a period of bed rest, it can be exacerbated by that. You can have GI symptoms of bloating and nausea and diarrhea, etc., fatigue, sleep disturbance, and they end up with all sorts of specialists being investigated. Pre-syncope is more common. They don't actually faint, but they feel very faint. But in some type of POTS, they can actually get proper syncope. And the syndrome, it can suddenly occur on change in positions, or it can be there a little bit or slowly come on over a period of time. And it can also occur in people who have been previously fairly active and exercising, because that doesn't change the nature of their pelvic venous disorder. So there is a gravitational physiology, obviously, to it. They stand, there's a postural change, there's pooling of blood, there's a decrease in venous return and stroke volume. Baroreceptor reflex is activated because these people are already hypersensitive autonomically, and then there's a compensatory vagal withdrawal, and the rest is easy to work out. The way to test is tilt table testing. A woman who presents with menstrual pain, with menstrual symptoms and chronic pelvic pain, we would do a tilt table test as well if they have some symptoms of POTS. And if you see this graph on the left, it is the heart rate change. The blue line tells you the dramatic shift in heart rate in people who have POTS. The gray line is men, and the orange line is healthy women. And you can also see the change in the stroke volume index on the right side in the graph when you do a tilt table test, even with a 60-degree tilt. So the mechanisms we think are many, but there are three basic types of POTS. There is a neurogenic POTS, where there is central nervous system issues with the autonomic nervous system. You have a hypoadrenergic POTS. These women tend to have slightly higher catecholamine release from the adrenal gland in response to the autonomic stimulation. They also tend to have arrhythmias. So when you're doing a tilt table test, it is important that one is ready to deal with an arrhythmia that may occur, and to terminate the test if the patient is feeling faint. And then the commonest type of POTS is, of course, related to blood volumes, and this is the one we usually see in women who have a pelvic venous disorder. There are two other conditions about a possible mast cell activation and possible autoimmunity. These are controversial, and there is no definite evidence to pin these two diagnoses down. Which then nicely brings us to the SVP classification. Like in varicose veins, you have the CEAP classification. In May this year, we published the SVP classification. The classification was led by Mark Meissner from Canada, and it has now been adopted by societies around the world. It was published in the Journal of Vascular Surgery in May this year, for those who are interested. And essentially, the SVP classification, SVP stands for symptoms, venous reservoirs, and pathology. And the pelvic venous disorders are divided on the basis of 4 zones. Zone that is shown on the right. Zone 1 is the left renal vein and the renal hilum area. Zone 2 is from there down to the pelvis, but above the pelvic floor. Zone 3 is below the pelvic floor, but in the region of the superficial perineal pouch. And Zone 4 is actually the lower limb. So essentially, symptoms tend to be related to where the variceal reservoir is. So if it is in the renal hilum and they have renal varices, then they will get flank pain and hematuria as a prominent symptom. Zone 2, they will have chronic pelvic pain. They can have some dyspareunia on deep intercourse, urinary and GI symptoms, of course, but Zone 2 is the commonest form of pelvic venous disorders. Zone 3, they have the standard vulvar, gluteal, perineal varices, and again, dyspareunia. And this dyspareunia can be both coital and postcoital, because there are paravaginal varices involved now. And Zone 4 are essentially venous hypertension in the leg pain and leg swelling, and varicose veins. Remember, menorrhagia tends to occur when the predominant reservoir is in Zone 2, because they are uterine varices that are involved. Then the venous reservoirs in Zone 1 are the renal hilar. The pelvic plexuses are Zone 2 from the gonadal and internal iliac veins. The extra pelvic plexuses that are below the pelvic floor are Zone 3, and all the veins in the lower extremity come under Zone 4. And the pathology is vessel specific. So for example, we will describe it as LR, being the pathology for left renal, or gonadal as G, or LG would be left gonadal. And then you have basically a pathology of pure reflux, obstruction, which can be post-thrombosis or non-thrombotic, like in the iliac vein, or it can be congenital, which may be a malformation of some sort. So this is the transuterine variceal arcade that I've been talking about. For some time, there's been a myth that pelvic congestion syndrome does not cause heavy bleeding. That is absolutely not true once it's become a pelvic venous disorder. And you can see this is a patient in supine position, not doing a Valsalva. And the contrast goes straight down the left ovarian vein. And then you can see the uterine arcade from the left side to the right side. And this is what leads to the heavy bleeding that these patients can have. So menorrhagia is zone 2 varices. Why am I going over these symptoms again? Purely for you to understand that a really good history allows you to know what would be the primary pathology and where the venous reservoir is likely to be. But then the classification, although it was only designed to describe a particular disorder so that we can compare like for like when we do publishing, but it also allows you to guide treatment, because the symptoms actually tell you what is the key problem that is affecting their quality of life. Are they having flank pain and hematuria? Is that the big problem? Is sexual pain the big problem? Is chronic pelvic pain the big problem? The leg pain the big problem? Where does the index symptom lie? Does it lie in zone 1, 2, 3, or 4? The venous reservoirs tell you where is the problem, and that should be our target of intervention. We are trying to reduce the size of that venous reservoir, or at least ablate it to the extent we can. So that tells us what is our interventional target. And knowing the pathology tells you what is the solution. For example, if the main problem is reflux, then you've got to stop the reflux from occurring. If the main problem is obstruction, like in the iliac vein, then you have to open up the iliac vein with a stent if required. So this allows us to make judgments on treatment as well. So a stepwise approach is required, and in our venous clinic, which we set up in September as a sort of satellite clinic of our Harley Street clinic, we follow a dedicated stepwise protocol. The first thing we do is a PCS questionnaire, and I will emphasize this as we go down, because this allows us to know what is really the likelihood of somebody having a venous problem or a gynecological problem. And then you look at the key index symptom. Which zone does it come from? You look at menorrhagia. Is that an important symptom? Because if menorrhagia is an important symptom, then there are some treatment implications to it in pelvic venous disorders, which we will talk about in a couple of weeks. Is low back pain a predominant symptom? That immediately means there's a pelvic floor issue to deal with. Is POTS a problem? So there might be more than just a pelvic venous disorder. Patients with POTS also have weak pelvic floors, and often many of their symptoms will get better with a high salt diet. I mean it, a high salt diet, up to 2 grams a day, unlike what we normally tell people, and with compression, leg compression, which allows at least the leg part of the variceal pool to have a better venous return. Compression and high salt diet and NPFF, Daflon at a high dose, are the primary treatment for the POTS symptoms in patients with pelvic venous disorders. And then there is a psychological impact. There are many parts to this. Firstly, chronic pain itself can lead to a fair amount of depression. And if it is cyclical chronic pain, then they get a huge amount of anxiety as the period approaches. If there's sexual pain or prolonged bleeding, then their relationship with their husbands and partners can be impacted, and that has a huge amount of relationship issues that come into play. In addition to that, is probably the biggest problem, which is one of dismissal. Their family, friends, and clinicians who they have approached before, who may not know about this, tend to dismiss their symptoms and say, oh, you just need to live with it or get on with it or learn to deal with it. That dismissal itself is a cause of fairly serious psychological discomfort in these patients. So this is the PCS score. You have what we call a basic PCS score. This was developed at the Venous Clinic by us. And we have now, and we are due to present it at Charing Cross in April, we have a high correlation with a duplex ultrasound findings, which is to say patients who have a high score on pelvic duplex ultrasound are likely to have a high degree of hemodynamic disturbance. The first 6 questions are given 1 point each. It is a basic PCS score, and it is not PCS specific or pelvic venous disorder specific. Do you suffer from pain in your legs on standing or sitting, or swelling, pain in the buttock or perineal region, coital pain, pain during micturition that's passing urine, and is it related to your period? But the PCS specific score has 2 points each. So the varicose veins in the groin or in the vulvar region after pregnancy, or if they've had it during their pregnancy, that suggests that there's already a leak through the pelvic floor. If they have post-coital pain, that is far more specific for a pelvic venous disorder. If they've had previous gynecological procedures for this pelvic pain, they've had laparoscopies, they've had implants, and referrals to chronic pain. So they have been looked at before, and other gynecological conditions have been ruled out. And then a pelvic venous disorder is obviously far more likely. And if they've had a CT or MRI for abdominal pain for whatever reason, and that has already shown dilated veins in the pelvis, you associate that with the pelvic pain and symptoms they present, and that makes a pelvic venous disorder far more likely. So you have 6 points for the basic PCS score and 8 points for a PCS specific score. You add them up, you get a total score out of 14. And we find that scores of 0, 1, or 2, even in patients who have severe pain, if they have low scores, they're unlikely to have pelvic congestion syndrome or pelvic venous disorder. They almost certainly have endometriosis. Between 3 and 6 is a bit of a gray area, and you might need to tease out the history a bit more, and you might actually need to do an ultrasound to work out whether it's a venous disorder or an endometriosis. But patients who have scores above 7 almost certainly have a pelvic venous disorder underlying their symptoms, and they will need a full clinical assessment to consider what needs to be done. So the score is fairly simple. If you've got your mobile, go onto our website, venusclinic.sg. This is the first thing that comes up, and you can run your patient score with your phone in your hand. And if it's 0, 1, or 2, please send to a gynecologist. If it is 3 to 6, tease out their history. If it is 7 to 14, please send to a vascular interventionalist who is well-versed with dealing with pelvic venous disorders. So it's a fairly easy way to do a self-assessment, and it is also an easy way to do a referral on who the patient needs to go to. And that's there on our website, so please feel free to explore our website because there's a fair amount of information on it. Now that we think it's a pelvic venous disorder, a transabdominal transvaginal duplex, which is a dynamic study, assesses the functional hemodynamic status of the pelvic veins. Do not do an intervention based purely on a CT or MR, because like I said, many normal people will have some degree of compression. Many women who've had 2 or 3 children will have some dilated veins in their pelvis. We will have a dilated ovarian vein. We will have both ovarian veins dilated. And we have also found that if you treat the left ovarian vein, the right ovarian vein size comes down as well, because there is a cross circulation between the two. So it is important that the decision to intervene and to diagnose a pelvic venous disorder is never made on a static CT or MRI. If that's one message on diagnosis to get across, they must have a live dynamic ultrasound assessment to see specific things. I will cover this more in the next talk, but specifically we are looking for spontaneous, not just Valsalva-induced reflux in the left ovarian vein. We are looking for reversal of flow in the internal iliac vein. We are looking for loss of phasicity in the pelvic veins, and we are looking to see if the velocity of flow in the pelvic veins is less than 4 centimeters per second. We have fairly specific criteria for diagnosing a pelvic venous disorder. I will cover that in the next talk. But it is important that they must have a functional assessment. The other thing, like I mentioned, is pelvic floor. If there is a leakage to the pelvic floor from the ovarian side, you may not have access to the veins below the pelvic floor. And there will be associated abnormalities related to the pelvic floor, like urinary symptoms, some cystoceles, enteroceles, rectoceles, erythroceles. They can have overflow or stress incontinence. And these could well be improved with pelvic floor, targeted pelvic floor physiotherapy. Many symptoms of POTS can be managed with pelvic floor physiotherapy and salt and compression alone. They do not need an intervention. And if that is the primary index symptom presentation, which is POTS symptoms, then they probably should not have intervention to start with. They must undergo at least 3 months of conservative management, which will include a pelvic floor ultrasound. But the dynamic pelvic floor ultrasound directs the pelvic physiotherapist on which way to go. Is it an anterior pelvic floor weakness, a posterior floor weakness? And if you find rectoseals, enteroseals, or bladder cystoseals or erythroseals, etc., then you can refer them to the urologists or colorectal surgeons to deal with the pelvic floor on a regular basis. There is fairly published evidence that ultrasound-targeted pelvic floor physiotherapy is an excellent guide. And then you move on to cross-sectional imaging. It is at this point that we need to know if we need, what sort of anatomy are we dealing with, and to not miss any other gynecological or abdominal pelvic conditions. If they have hilar varices that we find, or there's abnormal renal function, we will do a MAG3 scan to look at differential renal function, because if the left kidney is being compromised by a nutcracker, then the treatment is not ovarian vein embolization. That vein needs, the renal vein needs to have its obstruction relieved. Not many people are doing renal vein stenting now, and there are technical reasons for that, but they probably will need open surgery. Our preference is gonadal vein transposition, but there are those who do renal vein transposition as well. We will talk about it the next time. You will then rule out gynecological abnormalities. You must test the urine for blood and proteinuria, because if there is proteinuria, even microscopic hematuria and proteinuria, then the left kidney is being compromised. And if there's low back pain and you don't see the hilar varices on your pelvic duplex, then they might need an orthopedic assessment to rule out an orthopedic lower back pain cause. But it is only at this stage that the CT and MR should come in. By this time, you have more or less pinned down the diagnosis and the degree of severity of their symptoms. So only now, based on an algorithm, should we plan an intervention. And on the left, I have listed a set of conditions of procedures that we would do. When do you do what, we will talk about later. The middle angiogram shows an ovarian vein coil being put into place. And on the right side, you can see an iliac vein stent being deployed. So there are various treatments depending on what the primary pathology and where the venous reservoir is. You might need an ovarian vein embolization, vein sclerotherapy only, sclerotherapy plus embolization, or liquid embolization. Iliac vein stenting may be required. If there are gluteal, vulvar, or thigh varices, sclerotherapy under controlled conditions may be required. Various combinations of this may be required. And never forget the supportive care, targeted pelvic floor physiotherapy, psychological support, because a pain memory can stay even after treatment, so they might need cognitive behavioral therapy for that, and high-dose Daflon or MPFF. So we will discuss the next time on how you make these choices, but all these options for various conditions are available. So this is the algorithm we use, and we use the acronym AQUAS. AQUAS stands for agony, which tells you where is the primary index symptom, where is the agony coming from, which zone. Q stands for quality of life. In those who have chronic pelvic pain, there is a chronic pelvic pain impact questionnaire that we would use. But does it really affect their quality of life? Does it stop them from going to work? Does it stop them from attending school functions? Does it stop them from doing things at home? Is it a significant impact? U stands for urinary symptoms, which means the pelvic floor needs to be assessed as well. O stands for other pathology ruled out. Other gynecological conditions need to be ruled out. And S stands for sexual dysfunction, because immediately a psychologist may be required if that is a significant problem. So we use AQUAS as our algorithm for how far should we go with our treatment. Should we just diagnose them, treat them with supportive care, or are they likely to need an intervention? And it's a good way to follow a path. And I'm introducing you to this algorithm today, but how we use this algorithm for diagnostics and treatment, I will talk about in 2 weeks' time. So in 2 weeks' time, we will essentially be dealing with pelvic venous disorders, and on a slightly more technical level, and we will look at specific assessments on a transabdominal, transvaginal duplex. What is the role of a dynamic pelvic floor ultrasound? What are we looking for? How do we plan these supportive therapies in terms of targeted pelvic floor physio, psychological support? What's the role of DAFLON? Which patient for how long, at what dose? How technically do you do an ovarian venous intervention? When to use a coil, when to use foam, when to use liquid embolization, when to use combinations of these, and when to actually embolize the right ovarian vein, which is rare. Whether they need an iliac venous stent, how do you do an iliac venous stent for a pelvic venous disorder? How is that different? And of course, like we said, they can have varicose veins, not just in the groin, but in the lower limb because the systems are connected. And how do you plan the leg intervention? Do you do the leg first and then the pelvis? Do you do the pelvis first and then the leg? Do you do both together? Or do you just treat them with compression? So we will talk about that and how to make those choices. We will talk about how to deal with vulvar and gluteal escape veins and varices, which are often associated with the pelvic venous disorder. And I will briefly go over open gonadal vein transposition the next time for those who might be interested in that kind of open surgery. So that is, in a nutshell, how you sort of tease out the symptoms, decide whether to go down the gynecological or the vascular route for patients with chronic pelvic pain and menstrual symptoms. Please do visit our website to find out more on www.venusclinic.sg, and my email is up there, both the Venus Clinic email as well as my Harley Street Clinic email, where the interventions are actually done. And I would be delighted to take questions from you all and try and answer some for you today. Thank you very much, and thank you again, Doc Plexus. Thank you, Venous Association of India. In particular, thank you, Dr. Bedi, for having organized this, and I will take questions from you now. Thank you. I will stop my share now, if that's okay.
Sure, sir. So it was an absolute pleasure listening to you, sir. Very well presented session, sir. So we have a few questions from the audience. With your permission, let's go on to the first question. Okay, what factors should a physician keep in mind while using imaging as a diagnostic tool?
Okay, it is important, and I hope I managed to emphasize that during the talk. It is important to understand that ultrasound, CT, MRI is not an investigational hierarchy followed by venography and IVUS. That is not true. Please do not use that. Ultrasound is a key part of the diagnostics in this because you are actually seeing dynamic blood flow. We are looking for spectral Doppler imaging changes in phasicity of blood flow to say there is an obstruction, that there is pooling of blood, there is slow flow of blood, there is spontaneous reflux in the left ovarian or the left iliac vein. So that is a key part. The one thing that if I can get across to the person who asked this question and to the audience is that seeing dilated ovarian veins or dilated pelvic veins is not a pelvic venous disorder. That is fairly common. Also seeing some degree of renal vein compression on a CT, especially if you start doing a 3D reconstruction, or seeing some degree of iliac vein compression on a CT, that is not a disorder. It is so common now, 70 to 90% of us have it unless you walk on your hands or you walk on all fours. So that is not an indication for intervention. You must have a dynamic understanding of the blood flow in the pelvis. So ultrasound duplex is the first step and often the key step in the management of these patients when it comes to imaging.
Very well explained, sir. So we'll move on to the next question now. With overlapping clinical presentation, how should a physician approach pelvic pain to avoid diagnostic errors and provide optimal results?
Exactly like we went through in the beginning. So the two key chronic pelvic pain issues that we're trying to tease out, is it endometriosis or is it a pelvic venous disorder? Both of them have similar symptoms, you're right. But the first thing, many babies or no babies? Easy. Endometriosis, relative infertility. Pelvic venous disorder, relatively a lot of children. So that's one easy start. The pain during intercourse, it can be difficult to tease that history out. It takes some time to break the ice with the patient and to get for them to get comfortable with you to talk about it. So it might take 1 or 2 or 3 consultations. But that is a very important history. Post-coital pain does not occur in endometriosis. Coital pain can occur both in endometriosis as well as, like I said, if there are paravaginal varices, you can get coital pain as well in pelvic venous disorder. So to tease out, when does it hurt? During, or do you feel an ache afterwards? That is a very important symptom to try and take. Cyclical nature of the pain. Early endometriosis, it will follow the cycle because of the hormones, and the endometriotic tissue, which is extrauterine, will have the same sort of hormonal influences as the uterine tissue. So it will be cyclical to start with. In late endometriosis, when all the scarring, etc., has occurred, then that cyclical pain goes and they have pretty much pain all the time. But try and take them back to when the pain first began in their life, when they were 19, 20, 24, and find out what was it like at that time. That gives you a clue that did it start as endometriosis or was it a pelvic venous disorder. Then symptoms of POTS. Although there can be fainting because of the pain and the severity of the pain, it is not common for symptoms of POTS to be with endometriosis. POTS symptoms are really typical of a pelvic venous disorder, obviously because of the volume shifts involved. So it is quite possible, if you go stepwise in the history, to try and tease out, are we going down the gynae route or are we going down the vascular route? And then finally, surprisingly, we found is the PCS score. We've had people with severe chronic pelvic pain impact questionnaire scores, who, when they actually do the PCS scoring, will score 1 or even 0. And then that seems odd. You take them in for a pelvic duplex ultrasound and there are no varicosities. It is just endometriosis. So the distinguishing ability of the PCS score, it is over 90% specific and about 93% sensitive. We will be presenting this data soon, if of course Charing Cross accepts the data, but we think they should be accepted. But it is a very discerning way. So if there's one thing a patient wants to know, or a physician, general physician wants to know, or someone who's not planning to manage these patients wants to know, if you get a patient like this, open your phone, go on our website, it's free, just run the score. And like I said, 0, 1, or 2, send to a gynecologist, 7 and over, send to Rahul or somebody, or Dr. Bailey or somebody who knows how to deal with pelvic venous disorders. And in between, you might need to do a bit of testing to find out between 3 or 6 which of the 2 routes. One must remember that these 2 conditions aren't exclusive. There is no reason why a pelvic venous disorder cannot occur in a patient who also has some endometriosis. We have also noticed an association between IVF, or patients who had IVF, which is on the rise, and pelvic venous disorders. We know that people who have pelvic venous disorders tend to have low fertility sometimes because they have early pelvic venous disorders and they go in early for an IVF. And so they might have one baby from the IVF and then have proper pelvic venous disorders. And it is not that the IVF causes the disorder. It is the fact that there is some degree of subfertility sometimes in patients who have a bad nutcracker. And that may show later on in life. So there's an association of higher IVF use, obviously, in these patients. But it's not. But that is not to say treating a pelvic venous disorder is treatment for infertility. Absolutely no. The treatment of infertility still needs to be an IVF approach. It's just that we've noticed this association.
Thank you so much for such a detailed answer. We'll move on to the next question now. How should a physician decide whether medical management or surgical management would provide the optimal result for the patient?
AQUAS. That's what the protocol is about. If their quality of life is not significantly affected, if their index symptoms are fairly vague in terms of where the agony is coming from, if they don't have major urinary symptoms, or they have some urinary symptoms, if POTS is a predominant symptom, in which case pelvic floor physiotherapy could be a huge, it will abrogate most of the symptoms of POTS. If sexual dysfunction is not a huge problem, intimacy has not gone haywire, they have not had threatened split marriages or divorces or issues with their partners, and if you haven't yet ruled out other gynecological pathology, don't go into intervene. You shouldn't be doing surgery. So AQUAS is our guide. In the end, you have to remember, we are treating a functional disorder leading to a set of symptoms. You are treating symptoms. You are not treating a picture. You are treating people. So do not try to treat the dilated vein in the CT scan. If that is the one message I can get across, it is this: treat the person and the severity of their symptoms. Don't leave coils and implants and stents in people whose symptoms don't justify the intervention. However easy it might be and however lucrative it might be, please don't do it. You have to treat the symptom, and we have a target in the venous clinic that 3 or less than 3 in 10 will actually have an intervention. And that's not because we are trying to set a target, because in fact 3 or less than 3 actually need an intervention. 7 out of 10 will get better with pelvic physiotherapy, with Daflon, and with, if they have POTS, with a bit of salt, some Pilates, some weight loss if they're heavy, so in which case it will be an iliac issue, or if they're too thin, we ask them to eat a bit more, and their Nutcracker gets a bit better, and some psychological support, and they actually get away with it. You don't actually need to put implants in these patients. So don't treat pictures, treat people. Use their symptom severity to guide you, rather than the gross thing that you see on a CT scan. For example, like the CT I showed you. If you see a CT like that, say, oh, this patient needs a stent. That's not true. You haven't even made an assessment of their symptoms yet. Unless you do that, don't treat a picture.
Thank you for that answer. This was the most detailed presentation. That's what I have to say. And of course, I believe doctors would be waiting for your next presentation on 31st December. So this brings us to the end of this session. Thank you so much, Dr. Sriram, for your time and effort in putting together this interesting session.
Thank you. I look forward to seeing you all in a couple of weeks. That is a little more technical, I have to say. There's a lot more videos and stuff like that.
Sure, sir. We'll meet again, sir.
Thank you. Okay. So, bye-bye. Thank you. And
yes, to our dear viewers, thank you so much for attending this session. Do share any more questions if you have. Do block your calendar for the part 2 of this session coming up on 31st December at 6 p.m. Until we see you again, take care and happy doc plexing. Thank you.
Bye-bye.